Good evening. The sun is setting. We're here in Coronado Beach, lovely San Diego, on PI Today podcast. I'm your host, Dr. Nick. I'm back. I got a full tan and don't mind the sunglasses because the sun has not set yet and I don't really want to go blind giving you guys a podcast. So today we have another amazing guest, Dr. Krishnan Chakravarthy.
Perfect. Yes.
Right?
Yes.
Yeah, my last name is not something to brag about either. Dr. Krishnan is pain management doctor, anesthesia pain management. Doctor, thank you for coming on board.
Thanks, Dr. Nick.
I
Appreciate it.
appreciate you here. So, Doc, tell us about your education, your background, and what you do.
Yeah, sounds good. I'm not surprised. Chakravarthy is such a complicated last name, and
Well,
so
it's not complicated. I'm just waiting for my dish to get out here.
so I say laughingly, you could pretty much figure out what part of India somebody's from based on how complex their last name is. So I grew up in the southern tip of India in a place called Chennai. It's a very much small fisherman town. Born to amazing immigrant parents. Got to the U.S. when I was 6.
Okay.
Grew up in upstate New York, in Buffalo, New York. So that's been like my hometown, and I'm hoping the Bills get to the Super Bowl this year.
So
but
you must be loving this California weather.
you
Yes,
wouldn't believe
Buffalo
it.
is not
Buffalo,
a place.
not a place to
Yeah,
live. Yeah,
that's right.
And I don't think I could convince my wife either to move down there or the kids. So
Right.
I did my undergrad at University of Chicago, and then most of my education in the East Coast. So anesthesia at Hopkins, and did the whole Mass General
Bravo.
interventional pain fellowship. Came down to UCSD, was a faculty for about 5-6 years, and then saw the in some ways the greener pasture. So went into the private practice side. So our practices in both in Temecula and near across from Sharp Hospital. And I do 1 day a week. I see the veteran population, so keeping in touch
Well,
with
that's very nice.
Yeah, it's really nice.
So in pain management, of course, people are familiar with pain management. And I always say there's pain management and then there's pain management. It's
Yeah.
such a broad saying, I would say specialty. Doc, it's some of the things that we were talking about earlier in pain management, chronic headaches, CRPS, sciatica. Tell us some of the things that you see patient demographic.
Yeah, it's a great question. Very fortunate to be in a time where I think pain management as a specialty, the identity of a pain doctor is changing. It used to be that probably 15 years ago, all you could do was prescribe opiates. It was
That's
like
right.
pain was a fifth vital sign. Primary care thought of pain as just medication management. We've seen really a revolution in that. I mean, I think you see so many different approaches to a lot of the common indications that you say. I think what's really changed is that the identity of pain management today is much more interventional. I think when you think about the injections that we do for specific things like CRPS or headaches, or even some of the implantable devices that are being used. Nowadays, we kind of coined that term minimally invasive spine options. So I think we're going through a re-identity kind of way to rephrase who we are in that treatment paradigm. We were just talking before, even a lot of the things like ketamine infusions to looking at novel pharmacologic therapies. It's amazing what patients can get access to.
That's right.
But the big challenge for us as a specialty today is that if you don't see the right doctor, how do you know? I mean, it's the difference between somebody offering you the only thing is med management to surgery versus a host of different procedures that we can do. So I'll give you a good example. Spinal stenosis in the old days used to be a single to 2 level fusion. We now do a thing called mild therapy, which is an incision about 2 to 3 centimeters where we debulk the ligament. It's probably a 15-30 minute procedure, and you walk home that day.
Amazing.
And you don't do any take away any of the bone or any part of it. So if I think a steward to the specialty and how important it is to really empower patients with knowledge about what's out there. I think it's an amazing thing to be able to be a part of this podcast and really spread the word about what other options patients have. And I think it's really, really important.
Exactly. And since the demographic is, personal injury, heavy impact, musculoskeletal, herniations, real bad. And I guess the word soft tissue, some people like using that to minimize people's pain. But soft tissue is a real thing. You know, your discs, your ligaments, your muscles. I mean, these things get affected and they swell up. Nerves get irritated. Things burst, and the first line of defense is pain management.
Correct.
And in your novelty bag, when it's you have spinal cord stimulators. Obviously,
Yeah.
you implant those. Tell us a little bit about spinal cord stimulators because people can say it by name,
Yeah.
but I don't think many people know its application and what it does and how it does it.
Absolutely.
So, what does it do?
Yeah, so it's interesting. In 1968, there was a surgeon by the name of Norman Shealy. He saw a palliative care patient that had terminal cancer. So at that time, the whole point was gate control theory was this idea back in the Egyptian days, people used to stick their legs in water with electrical eels. And the thought was that electricity by in itself, if you send an electrical signal, it can actually block the transmission of pain coming from your peripheral nervous system to your central nervous system. So he took this idea, implanted this like literal two contact lead in the subdural space, which is right next to the spinal cord, and he stimulated. And it was fascinating. The patient basically said, I have no pain. And this was a terminal cancer patient. So imagine the last 70 years, it has seen a prolific advancement in our understanding of how nervous system communicates and what we understand. And so the basic premise is what you're really doing with spinal cord stimulation is you're creating an electrical current that blocks that transmission of pain in your spinal cord as it goes from your distal extremity to the brain. And I've been very fortunate to be able to pioneer some of the newer devices that have come out. The last and most recent one is what we call a closed loop spinal cord stimulator. What it actually does, it measures electrical signals in the actual spinal cord and decides what therapy amount to give. So you're mixing different amplitudes, frequencies, and
Wow.
signals that really help. So today, if you think about spinal cord stim, we look at persistent spinal pain, people who've had back surgeries that are just refractory, that they can't get any more improvement. We've treated complex regional pain syndrome with it. We've treated all kinds of different things. We even gotten people to walk with some of these different stimulators where you can bypass a lot of the neural signals that are disrupted. So I think when you think about acute injury from a trauma or an accident, it's really powerful because imagine I think we need to get out of this idea it's just not about pain. It's about rehabbing somebody to get them to a better quality of life. So for me as an interventionalist, I'm just not just focusing on pain. I'm looking at sleep. I want them to have a good quality of life. I want them to be back to where they were with their loved ones before the injury. So these types of technologies are really impressive, and I think they're revolutionary in their way that they're being
Amazing.
applied.
So, take us through physically
Yeah.
how you do a trial, and then what do you need to see from the trial in order to do a permanent implant.
Yeah.
So, how does the procedure start?
Yeah. So what happens is that if you come to the clinic, you've had an acute injury or a chronic injury. I think it's really important to make sure you make the right diagnosis. One of the things I really think about the value I provide as an interventionalist pain doctor to my very multidisciplinary PI colleagues is whether they're from chiropractic or any part of it is I want to provide comprehensive care. So once I've determined that they've failed conservative therapies, they've tried all of these things, and I think that there's a true radicular pain that's unilateral or dermatomal, then I go for a trial. And that usually requires a pre-psychological screen to make sure that there isn't something that I'm missing. So what happens is they come on the day of. It's like a kind of like an epidural. We use a small 2E needle that inserts two 8 contact leads that go in the epidural space using an AP and lateral view on the fluoro guidance. And once those leads are in place, we ask them questions like, hey, if I stimulate, does that overlap with the
And
area
what
of
do
your
those
pain?
leads look like? Do they look like long
They
wires?
look like long wires, and
Right.
they're made of platinum iridium, and they've got some coatings to make them MRI compatible. And then they've got little tips at the distal part of it that actually stimulate. So once they have a positive response to that trial over 7 days, we do pull out the lead. Then we schedule them for the implant. the implant itself, there are small batteries, about anywhere from 13 to 22 cc volumes. Nowadays, these systems last 15 years. Once they're implanted, they go right underneath the skin, and they're 3 Tesla MRI compatible. So amazing technology that's come up over the last 3 to 5 to 10 years. I think generally there's been a very healthy skepticism around stim, right? You talk to our surgical counterparts like, oh, that stuff hasn't worked. Why would that work? Well, in the last 10 years, the evidence has really grown. And I think it's worth really revisiting that. I think it's important to understand all the benefits around it.
Amazing. And the regular stuff, the epidural, cervical, lumbar,
Yeah.
radio frequency, all that stuff is no problem.
No problem. And the hope is that you don't need it. I think what we are recognizing is the data supports that you don't really need ongoing adjuvant therapies that you've done. You might have already failed the conservative injections. We're also really looking at how to titrate these people off a lot of their opiates after the fact to try and get them to rehab faster, essentially.
Got it. So, doctor, you are a rarity. I don't get many MD PhDs. So what's your PhD in?
It's funny that you asked. So I was a gluttony for punishment. So I did. So I worked for an anesthesiologist who, Dr. Paul Knight, very influential in my life. So you would have this joke that there's a bowl in his room. It was called Ashes of Problem Students. He'd be like, Krish, you are overflowing on the brim. I can never tell you what to do. You just want to do your own experiment. So I actually, interestingly, did a lot of my work on viral immunology. So I actually developed vaccines for 1918 flu. I spent a good part of my year or two working at the CDC, which came very handy during the whole COVID part of it. So, and so I actually had a lot of the theories from my CDC colleagues about all of that piece of it. And then I did a portion of it in engineering. So I was designing a lot of different drug delivery systems for vaccines and gene therapy. So, of course, I got back to anesthesia, but I've been very fortunate in my life to do a lot of different things, and it's paid off in some ways.
Wow. Well, that's impressive.
Yeah.
Yeah. I wouldn't want you as my parent. There's going to be a shortcoming. Well, that's amazing. Dr. Krishnan, thank you so much for coming on our podcast.
Yeah.
Pain doctor, interventional pain physician in the San Diego and Temecula area.
Yeah.
Is that 2 offices or 1 office?
We have 2 offices, and
Where's it located?
the
Exactly?
one is up in Temecula, Murrieta, and the other
Okay.
one is down near Linda Vista, near Mesa College Drive.
Linda Vista. And now they're both in Temecula.
Oh, and one's in I wouldn't say downtown San Diego, but one's closer to La Mesa, and the other one is up in.
Okay, got it.
Yeah.
So Doc has clinic in San Diego and Temecula, which is very hot areas.
Yeah.
Make sure you guys send to him a scholar, a wonderful expert with his credentials. He would make an incredible expert.
Yeah.
I vouch for him. And thank you for joining us today, Doctor.
Yeah, thank you. Thank
All
you
right.
very much. Appreciate it.
And that concludes our San Diego tour. Join us next time. I don't know where, but as soon as I find out, I'll let you guys know. Take care.
Thanks for listening PI Today podcast, sponsored by Trauma Cash, Global Lean Doctors and TBI Analytics. You can find us on our website, www.pi2daypodcast.com, also on Instagram, YouTube, Spotify, TikTok, and LinkedIn as PI 2 Day Podcast to watch all our episodes. See you next time.